Hi, I'm Dr. Jared Gardner. Thank you so much for inviting me to speak virtually at the AAOMP meeting. I'm going to talk about some dermatopathology pearls with a focus on lesions that arise in the head and neck, so that hopefully it will be helpful to those of you who are oral and maxillofacial pathologists who also see skin. These are my disclosures. I don't think any of them are particularly relevant except for the fact that I do receive royalties from my textbook that I published with Innovative Science Press, and I'll be using a lot of images from that book today. But you can see a full list of my COI here at this link. And also, this is my contact information, and these are my 3 daughters, so I'm raising a dermpath empire in my household. I also have a library of pretty much all of my videos and digital slides, images, and I'm a growing list of sample pathology reports for how I sign things out and what language I use in real life. You can check those out. Those are the links right there. Oh, and I do receive ad revenue related to views of my posts on YouTube and on Kiko XP. So if you're not okay with that, then please don't click these links. But otherwise, feel free to check them out. I want to release this stuff free so that it hopefully helps other people in better understanding dermpath and bone and soft tissue pathology. So we're going to go over skin adnexal tumors, again, with a focus on entities that can sometimes occur in the head and neck. I'm going to talk a bit about a couple select spindle cell tumors that are relevant to the head and neck and can occur near the skin, and also a few tips on melanocytic lesions, particularly on how to recognize melanomas and not misdiagnose them as something benign. So the basics of skin adnexal tumors is a very big, complicated area of dermpath, and dermpaths love to argue over it over the years. But basically, to simplify things, I think you can break them down into sebaceous lesions, sweat gland or duct lesions, and hair follicle lesions. And I wrote a paper about this with my colleagues Ed Fulton and Jennifer Cayley a couple of years back. It's in a special issue of Archives that we put together that was based on dermpath with a focus on general surgical pathologists. So you can check this paper out if you want, and everything in that issue and the following issue is all basically dermpath for general pathologists. So you might find some of those papers useful. All of the other authors we invited are really great, and they wrote a lot of nice papers, and it's all available for free on the Archives of Pathology website. So the normal skin adnexal structures, of course, are sebaceous glands, the sweat glands and ducts, and hair follicles. And so, of course, skin adnexal tumors are either derived from or show histologic differentiation into those kind of general categories. I'm going to, again, talk about the basics, and in real life, there are plenty of lesions that have overlap or show more than one category, and those can be a little bit more complicated sometimes. So these are the clues that you're going to look for. I think I list them in this order because I think the easiest thing oftentimes, with some exceptions, is if you see obvious sebacites, then you're probably dealing with a sebaceous lesion. If you see glands, ducts, or tubules, then you're probably dealing with a sweat gland or duct proliferation. And finally, I put hair follicle lesions last because I think they're sometimes the hardest to recognize because they have a lot of overlap with basal cell carcinoma and other things. They have basaloid cells, palisading, and a kind of unique cellular spindly stroma. Okay, the very simple way that I explain, like to beginning residents, how do I know if something's an adnexal tumor? Well, if you see an epithelial cell tumor in the skin that doesn't look like one of the common typical things, it doesn't look quite like a basal or a squame or a seborrheic keratosis or something else common, but it looks epithelial, then the things you should think of are, first of all, is it a metastatic carcinoma? I guess I should have put that first in the list here, but I think of skin adnexal tumors, metastatic carcinomas, and also in the setting of the head and neck, I always want to think about, could it be a salivary gland tumor that's pushing up into the skin from the underlying parotid or the submandibular gland, or even one of the minor salivary glands if it's on the lip, for example. Obviously, as head and neck pathologists, you're all very familiar with the morphology of those lesions, but I think it's always important, and I always try to think about, could this be a parotid tumor if I'm on the cheek and it looks like an unusual adnexal thing? I try to make sure I'm not missing a salivary tumor. So sebacites, we'll start there. Sebacites normally produce sebum, which is a lipid-rich fatty secretion composed of broken down mature sebaceous cells. So sebacites are going to be filled with lipid, which means they're going to have clear, sharply circumscribed vacuoles, usually that indent or scallop and push into the nucleus. They're little clear, round bubbles. So finding those clear, sharply demarcated bubbles is, to me, the key for recognizing sebacites. Now, that said, I do sometimes see clear, sharp vacuoles that look, for all the world, to me, like lipid droplets, and I see them in the setting of something like Bowen's disease or squamous cell carcinoma in situ or other things. So sometimes you can see clear droplets in other cells. Also, a lot of different types of skin tumors, both squamous cell carcinomas, sometimes basals, other adnexal tumors, can have glycogenation and clear cell change from other backgrounds. So that can sometimes be challenging. But basically, this is the simple explanation is this is what you're looking for to see sebacites. Okay. Now for sweat ducts, usually those are going to be sharply demarcated spaces within the tumor. And sometimes they can be large spaces. They can become a little irregular, but usually have kind of a crisp margin around them. Or they can be little tiny holes that look like little vacuoles or very small ducts. So depending on the tumor, they can really range a lot. This particular example, a poroma, we'll talk about later, really shows a range here from these dilated ductal spaces all the way down to these tiny little, almost intracytoplasmic lumens. Here's another example of sweat ducts. This was a spiroadenoma. And again, I'll show you another example. The reason I point this one out is sometimes the individual ductal spaces are actually even lined by their own unique independent layer of cuboidal cells, kind of recapitulating the double layer of cuboidal epithelium that you see in normal sweat ducts. This is a syringoma, and this one shows actual tubules that are suspended in the midst of the background dermis, kind of surrounded by sclerotic collagen. So this is a different pattern. Sometimes you'll see a large cellular mass with little duct spaces like I just showed you in that poroma or that spiroadenoma. And then here, though, other tumors actually make distinct tubules that kind of trickle in between dermal collagen. So there's kind of different patterns, but still it's making a duct. And in the middle of the duct, if you're lucky, sometimes you'll see inspissated or kind of congealed, dried up sweat secretion. So this pink material here and even those little dense blobs there, that's sweat secretion in the lumen of these ducts. And in this case, this was a syringoma. Now, follicular tumors, like I said, have kind of a constellation of features. Blue basaloid cells, often with peripheral palisading. And because of that, they can resemble pretty closely sometimes basal cell carcinoma. But the key to me that really helps is the stroma and the way the tumor islands interface with the stroma. Here you can see the stroma is this kind of dense, pink, collagenous, kind of more cellular stroma, and it tightly hugs the nests. There's none of that clefting artifact with mucin-filled space that you usually see in classic basal cell carcinoma. And additionally, if you're lucky, you'll find these structures with the green arrows highlight. These are papillary mesenchymal bodies. These are kind of round to oval stromal cells. I know they look round, but if you did a keratin, the blue islands would stain, but if a keratin immunostain would stain the blue islands of epithelial cells. But these cells are actually stromal cells. They are not epithelial. They are a specialized stroma that's recapitulating the stromal cells that you see around the hair root or hair bulb, which normally kind of regulate and control hair follicle growth. And so when you get certain hair follicle tumors, like trichoepitheliomas particularly, you'll tend to see these little structures. And sometimes they're big and beautiful, like this is the best ever example. Other times they're little tiny things. So this is a really good classic example to learn what papillary mesenchymal bodies look like. They're all clustered and kind of pushing right into and almost invaginating into those blue islands of basaloid cells, but sometimes you won't see that perfect cut. So you'll see this is a papillary mesenchymal body, but because of the angle of the section, and you can't actually even see the island of basaloid cells. It's like this island here would be like a cut straight across here, basically. Or other times, like I said, they're just this tiny, tiny little aggregation. So once you learn the classic ones, then you can begin to recognize them when they're much more subtle, kind of incipient papillary mesenchymal bodies. And that can be a really, really important clue for not only recognizing hair follicle tumors, but even recognizing little immature vellus hairs that sometimes, particularly at margins or on frozen sections, sometimes those can be a close mimic of a little island of basal cell carcinoma. So I've many times seen, residents and trainees particularly make that mistake and think something's a bit of basal cell carcinoma when in actuality, it was just a little tiny hair follicle. Like I said, follicular tumors, they have this stroma, and the stroma tends to be more cellular, and it tightly wraps and hugs the nests. It just wraps right around those nests, just like the stroma, the adventitia, which is the name for the stroma around normal hair follicles, just like that tightly hugs the normal hair follicle. So here, the cellular stroma of a hair follicle tumor tends to tightly wrap around the basaloid epithelial islands. And here's a contrast. This was a trichoblastoma over here. And in contrast, this is the kind of stroma in basal. There's this separation with mucin or myxoid material, whatever you like, bluish substance in there in that crack between the palisading and the surrounding stroma. So you'll often find that, not every basal, but many of them have that, and it's a very helpful feature. So let's go over some of the select sebaceous entities. Now, sebaceous tumors sound easy because there's only like 3 or 4 of them, with a couple of rare esoteric exceptions. There's sebaceous hyperplasia, which isn't really a tumor at all. There's sebaceous adenoma and sebaceoma, which in my mind exist on a spectrum, and we kind of make this arbitrary distinction between what name to give them. And then there's sebaceous carcinoma, which of course is the most important thing because it's a malignancy that can be more aggressive sometimes, and particularly when it occurs near the eye, it can really infiltrate the conjunctival epithelium and become a real big problem for those patients. So these sound simple, although the problem is that sometimes it can actually be challenging to decide, is there enough atypia to call something a carcinoma or not? And so in actuality, even though there's not very many of them, the distinction can sometimes be a little challenging, especially if you have only a partial sample. So sebaceous hyperplasia is the easiest, and these usually are yellowish papules on the face of older adults or middle-aged adults, and they often have this depression in the center clinically, and that's because you have this kind of dilated opening here, and so sometimes they call that a dell, D-E-L-L. Clinically, there's a little dimple or dell in the middle of these yellowish papules, but these can get confused with basal cell carcinoma clinically, and because of that, we will see biopsies of them from time to time because the clinician wants to rule out, the dermatologist wants to rule out basal cell carcinoma. The glands are just like regular, mature, benign sebaceous glands, except they're much bigger and more of them, and they're kind of clustered together into this nodule, and they tend to open into dilated spaces that often connect directly to the surface, although sometimes they can be associated with the hair follicle. But basically, they're just benign, normal sebaceous glands that are just really huge and more abundant than usual. Now, this in contrast with the sebaceous adenoma, and the big difference here is there's more prominent blue basaloid cells around the outside. You can see the entirety of these nests are surrounded by a thicker layer of blue basaloid germinative epithelial cells. This one also has some cystic spaces, and sebaceous adenomas, as many of you probably know, are sometimes associated with Muratori syndrome, which is basically so-called Lynch syndrome or hereditary non-polyposis colorectal cancer syndrome with the addition of sebaceous neoplasms of the skin. I would say that most of the time when I see sebaceous adenomas in practice and sebaciomas, I feel like most of them are sporadic and incidental, but a small subset of those patients do potentially have underlying Muratori syndrome. So it's an important consideration to keep in mind. And the way to work that up is actually pretty complicated, and we won't go into that because there's some debate over how to actually handle it. I usually just mention in my report, these are sometimes associated with Muratori syndrome, and I let the treating physician decide how to proceed from there. When there is cystic change in a sebaceous adenoma, there have been some studies suggesting that that's more highly associated with Muratori syndrome. And sebaceous adenomas, again, they have a more prominent layer of blue basaloid germinative cells. Scattered mitoses are a common finding, I would say. I find that oftentimes in sebaceous adenomas and sebaciomas, you will get the big clear sebacites like you see in sebaceous hyperplasia, but you tend to have a lot more of these kind of somewhat immature sebacites. They have a kind of grayish pink cytoplasm with only a tiny bit of bubble there. They've not fully filled up with lipid yet. So I find when I start seeing a lot of these kind of somewhat immature looking sebacites like you're seeing here, that I start thinking, oh, that's one feature that can sometimes help point me to something being a sebaceous adenoma or sebaceoma rather than sebaceous hyperplasia. Also, I just want to remind you that normal sebacites break down and die and become part of the sebum in normal sebaceous glands. So sebaceous tumors do that same thing. So don't get concerned about this quote-unquote necrosis here. This is not a worrisome feature to me. If I see bubbly, mature-looking sebaceous that are dead in little islands in the middle of a sebaceous tumor, that to me alone is not a sign of malignancy. That's the normal way sebaceous break down. That's how that's the normal process. If I start seeing a bunch of blue basaloid cells that are necrotic along with mitoses, then I might really start giving that some serious concern for maybe malignancy. And if I have a transected shave biopsy and can't see the base, and I have some unusual or atypical feature, then I'll say a sebaceous neoplasm with atypia, and then put a comment that I think it's probably sebaceous adenoma, but I can't see the bottom, and it might be a good idea to do a conservative excision so I can see the whole lesion. I don't otherwise think personally that sebaceous adenomas or sebaciomas must have to be excised with negative margins. Some people have different views on that, but my thought is that they're probably just fine and they're benign. The only time I really usually ask for excision is if I can't see the whole lesion and I have some concerning feature there that worries me that maybe we're on the top of something more aggressive like a sebaceous carcinoma. So here's a sebaceoma. You can see it's a nice circumscribed lobule or two, a couple of lobules there circumscribed. It's not very large or deep. I do start to get kind of concerned if I see deep pushing lesions that are large and push down into the deep dermis. It's not that that has to be malignant, but it starts really concerning me if I see large lesions pushing down that are sebaceous. But here the tumor has got mature sebaceous, like sebaceous adenoma, but over 50% of the tumor cells are basaloid. So that's kind of this arbitrary distinction or cutoff that we make, that if it's more than 50% basaloid, we call it sebaceoma. I'm not sure why we have that as the cutoff, but that's what the people have told us from history, and so that's what we tend to do by convention. And there's a closer look. Again, you can see obvious sebaceous here, and then these blue basaloid germinative cells in the background. Now, I want to point out that mitotic figures I find almost always in sebaciomas, and again in sebaceous adenomas too. So by itself, mitoses don't worry me. If I start seeing atypical mitotic figures, if I see pleomorphism or really obvious nuclear atypia in the basaloid cells, you can see these are hyperchromatic a little bit, but they're all pretty uniform. They're recapitulating the germinative epithelium that surrounds normal sebaceous glands. They're just more prominent here, but they're all pretty uniform and don't really, to me, look that cytologically atypical. Although I have to say, I know atypia is in the eyes of the beholder and is subjective to some extent. So, but what I learned this when I went and pulled some sebaciomas for a lecture I was giving a few years ago. I couldn't find a single sebaceoma in my entire recut collection that didn't have mitoses. So either I've misdiagnosed a whole bunch of sebaceous carcinomas as a sebaceoma, which I hope is not the case, and no one's come back to tell me that I have otherwise over the years. I'm knocking on wood here, but either that's the case or just sebaciomas have mitoses. So I think it's the latter, and hopefully I'm right about that. But if you see, atypical forms or pleomorphism, that's when you start getting worried, or infiltrative growth. Now, in contrast, here's a sebaceous carcinoma. And I think sebaceous carcinomas can take a lot of forms. Sometimes they can look basaloid, almost like basal cell carcinoma. Other times they look very squamoid. I feel like they tend to have a kind of an overlapping pattern between BCC, between basal cell carcinoma and squamous cell carcinoma. So if I see an ugly basaloid, squamoid looking skin cancer, and it's especially if it's on the face or near the eyes, I give strong consideration to the thought of, could this be sebaceous carcinoma? And there are various immunostains you can try, none of which are perfect, and you can read some more about that in that paper I referenced at the beginning of the talk. It's a little bit more than we have time to cover today in this lecture. But here, this is but just I think as a general rule, ugly malignancy that looks kind of somewhere between basal and squam, keep sebaceous in your differential, okay? And there's a closer look, and you can see the sebaceous here. There are little vacuoles indenting the nucleus, so clearly little lipid droplets, but they're not really beautiful, well-formed sebaceous like you see in the other benign sebaceous tumors I showed you just a bit ago. Now here's a different one. This one was very infiltrative, obviously malignant by its architecture and cytologically, but it looked much more squamoid and even has some keratin pearls in it. So I think this one, on a partial biopsy, I would have probably called a squamous cell carcinoma, but then down here we have obvious vacuolation and sebaceous differentiation. Look at that. perfect sebacites right there, and very atypical squamoid cytomorphology in this particular example. So they really can run a range. And I find the one challenge I find with sebaceous carcinomas is they often are either one of two things. They're either obviously malignant, but I'm not totally sure if they're sebaceous or not. These pictures are pretty obvious, but there have been many cases in real life where I'm kind of concerned and I never could quite find a perfect sebacite. So I find that you either have obviously ugly tumors that are clearly carcinomas, but you're not sure if they're basal cell or squamous cell carcinoma, or if they're actually sebaceous carcinoma. At the other end of the spectrum are the very well differentiated sebaceous carcinomas that you can tell clearly it's sebaceous, but you're not totally sure, is it malignant sebaceous carcinoma, or is it just a kind of a big, large sebaceoma or sebaceous adenoma? So again, that's I'm making it look a little more simple than it is in this lecture because I'm showing you select very good pictures of classic examples, but I've certainly encountered many cases in real life where I wasn't totally sure. And if I see something that it's a carcinoma and it's a little bubbly, but I'm not sure it's sebacites and the stains don't quite pan out, I'll usually say this is a carcinoma, and I think it's probably a basal cell or maybe a basaloid squamous carcinoma, but I can't be totally sure it's not sebaceous. And the goal there is that hopefully they will treat it more aggressively and make sure it's completely excised with negative margins. But in any case, you can again go into that paper and we'll talk about it in a little more depth there. All right, so let's go into sweat gland entities now. So in sweat gland tumors, what we have is we're going to talk about this pattern-based approach, and this idea really was my former fellow Ed Fulton came up with this when we were writing that paper for Archives a couple years ago, and I really liked his idea that you can kind of put them into these categories. And so I'm going to leave this here and not read over the whole table, but leave it here so that you have it for reference later. But basically, these are the kind of general groupings and categories, not based on whether they're ecrine or apocrine. I don't personally care about that. Some people get really hung up over what the embryologic derivation is. What I care about is, in practice, morphologically, how are you going to look at the tumor and recognize it? So to me, the pattern matters more than whether or not two tumors are actually related ontologically. So I don't know, that might offend some people, but I really care about the practical approach and getting the diagnosis right first and foremost. All right, so these are the kind of the basic groupings that we go into. So this is the solid pink pattern, and I think the family of solid pink lesions are kind of the acrospiroma family, which includes poroma, hydroadenoma, and a few other things. So poromas are composed of kind of a uniform population of these pink cells, and they are attached to the epidermis and then push these fingers of projection down into the dermis. They're often inflamed, ulcerated. On the top, they often have edema in the stroma. They tend to be very sharply circumscribed from the surrounding epidermis. You can really tell, like, these are the poroma cells, and they end exactly here, and then this is the epidermis adjacent. I find that a very helpful feature. Also, poromas tend to have these very small round nuclei that are really, really uniform, and I find that very satisfying to see visually. And this is the picture we looked at the beginning, showing the variety of different sweat duct types and shapes that you can see. I feel like in real life, if you're lucky, you'll get all this ductal differentiation, but sometimes I think something's a poroma, but I really am struggling to find any ducts. So sometimes you really have to hunt around to find sweat ducts in these lesions. I find that poromas can sometimes mimic other things, like seborrheic keratoses, and poroma can look pretty similar sometimes, and there are a few other entities that can come into the differential. Now, when you see those similar kind of cells, but as in nodules or islands in the dermis, or even sometimes the subcutis, then you can think of hydroadenoma. And there's another entity that some people believe in and others don't, called dermal duct tumor, which is probably closely related and on the spectrum between poroma and hydroadenoma. And the thing about hydroadenomas is they tend to have more abundant pink cytoplasm, a lot of times have cytoplasmic clearing, and they tend to have very large cystically dilated spaces filled with sweat secretion. Here's an example too. The stroma around a variety of sweat gland and duct tumors, particularly in hydroadenomas, tends to get very hyalinized and sclerotic. That's a common finding. Here's an example of that clear cell change from abundant glycogenation. And in rare cases, you can see almost complete 100% clear cell change in hydroadenomas. And those cases can very closely mimic metastatic renal cell carcinoma, which is a carcinoma that has a tendency to metastasize to skin. And particularly, I feel like I've seen it often on the skin of the head and neck. So a relevant entity for everyone here to know about. So make sure to distinguish those. An easy way to tell them apart is hydroadenomas, like many other, probably most other skin and adnexal tumors, tend to have strong diffuse nuclear expression of P63 and P40. So those are closely related markers, and you can use them. They're a really helpful marker for a variety of sweat gland tumors and other adnexal tumors. In fact, most epithelial tumors from the skin that arise from the skin, squamous cell carcinoma, basal cell, seborrheic keratoses, and the vast majority of adnexal tumors, both benign and malignant, will have nuclear expression of P63 and P40. And that marker is usually going to be negative in renal cell carcinoma. And there are other markers too, like Pax8 and on and on. But I really find P63 and P40 to be quite useful. In this case, I think morphologically, this looks great for a hydroadenoma, no problem. But I have seen a few that had extensive clear cell change. Here's another example. And I think cytologically, look, the cells almost look squamoid to me. They look very much like the cells that you would see in, maybe in a seborrheic keratosis or some other entity, that they look like keratinocytes. And here's sweat ducts, little tiny ones, bigger ones, and then more dilated ones. And this one here is lined by its own layer of cuboidal cells. Now, this is a spiroadenoma, which, despite the name, is totally unrelated to hydroadenoma. So I think the names of sweat gland tumors add a lot of confusion. But these are blue basaloid-looking islands, or blue balls in the dermis, blue nodules in the dermis or subcutis, and they're usually very sharply circumscribed. Sometimes they can get abundant, clear edema, of this pale areas of edema in the background that make them look really weird. But this is the classic appearance up here. They look very different than hydroadenomas because they're very blue, whereas hydroadenoma and other members of that family are very pink usually. So here the blue cells are packed together tightly in the middle of these blue nodules, and the sweat ducts are nice and circumscribed, and they're lined by a little cuboidal epithelium here. Now, some people like to talk about 3 different cell types being seen in spiroadenoma. These small little round blue cells, the larger, slightly more pink cells, and then scattered lymphocytes. And if you find that useful, great. But I find that for people just starting out, this is a kind of subtlety and nuanced thing that's difficult to recognize. And in not all spiroadenomas have it perfectly. So you may have heard of this before, and if you find it useful, great. But I find blue nodules and then little sweat ducts like this to be much more helpful than the individual cytology. But the scattered lymphocytes is a common and helpful finding. It's usually present in spiroadenoma. The other thing in spiroadenoma is you do tend to see a lot of basement membrane material, both as little tiny droplets or spherules in the midst of the tumor islands, and also as thick, dense bands surrounding some of the tumor nests. And look here, these are ducts. Now, these ducts don't have their own cuboidal lining, but they have a very sharply circumscribed border and this kind of thickened, darker pink layer around that border that we call the cuticle. So the presence of a dense pink cuticle, sharp circumscription, and if you're lucky, a little droplet of secretion, sweat secretion in the middle, that's helpful to distinguish a true duct from, an artifactual vacuole. And sometimes that distinction can be challenging. Here's another example of really abundant hyalinized droplets of basement membrane material, which of course is type 4 collagen, really common to find in spiroadenoma, and also in the closely related entity, cylindroma. I think of cylindroma and spiroadenoma as like brothers, basically, or sisters. They're very closely related, and sometimes they even coexist together in the same tumor. Poroma and hydroadenoma can sometimes occur together as a hybrid tumor, and cylindroma and spiroadenoma can sometimes occur together where you see both entities together intermingled with each other. And when I see that, I say spiroadenoma/cylindroma hybrid tumor. And with a comment, if it's not a dermatologist, I'll add a comment that this is a benign sweat gland neoplasm. And that, just so they're familiar that it's nothing scary, even though it has a weird sounding name. All right. So the difference is that cytologically, cylindroma and spiroadenoma to me are essentially identical or very closely, very similar to each other. The difference is in the way the cells are arranged with one another. In spiroadenoma, they're packed really closely into those big blue nodules, but here in cylindroma, they make small nests of varying size and shape, and those nests kind of mold and squish into their neighbors and mold and conform to the shape of their neighbors. See how the nests kind of all lock into each other like puzzle pieces. So some people say these are like puzzle pieces. Ed Fulton, my former fellow, liked to say they look like spots on a giraffe. I thought that was pretty clever, and I like that. And again, look, we've got really sclerotic hyalinized droplets of basement membrane material here in the islands of the tumor and also surrounding each of the individual nests. So very beautiful cylindroma. These often occur on the scalp and sometimes can be associated with syndromes like Brooks-Spiegler syndrome. All right, now here's a syringoma. Syringoma is that tadpole or paisley tie pattern that includes the four main entities that have that are syringoma, desmoplastic trichoepithelioma, infiltrative or morpheaform basal cell carcinoma, and microcystic adnexal carcinoma. So syringomas tend to have these little islands that have ducts in them. The ducts are easy to see usually in syringoma. You can clearly see multiple ducts. They tend to have a dense sclerotic background stroma, and you can tell, like, here's where the end of the tumor is, right? That stroma is very distinct and discrete from the surrounding dermis. And even though if you look in the middle, it looks kind of busy and infiltrative, if you see the whole lesion from low power, you can tell that clearly it's circumscribed and it's not infiltrative. These often occur on the cheek or right under the eye, particularly in adult women. But you can see them in other sites and in other age ranges and in men as well. And there's a closer look at the varying pattern that you can have these nice tadpole shapes, but also sometimes they'll just be little individual strands or clusters of tumor cells without an obvious duct. But usually the ducts are not hard to find and they're multiple. Now, the really pitfall is fortunately very rare, but is very hard to diagnose, especially on a partial biopsy, and that's microcystic adnexal carcinoma, or MAC, which usually occurs on the face of adults, and it tends to have that paisley tie or tadpole pattern. But a couple of differences is the ducts. Most of the MACs I've seen, the ducts were very difficult to see. They were very hard to find at the superficial aspect of the tumor, and usually I only found good ducts deep down in the tumor. Now, that's not always the case, but I find oftentimes, unlike a syringoma, which you're going to easily see multiple ducts, in a MAC you often have to really hunt for the ducts and they're hard to find. The other thing is that MAC has these keratin-filled microcysts, which are usually present in the superficial aspect of the tumor. Very useful clue. There is one other entity that looks very similar to MAC, and that's desmoplastic trichoepithelioma, and we'll talk about that in session 2. Here's the thing you're looking for in microcystic adnexal carcinoma. Is you want to see things that look almost like normal sweat ducts, but they're infiltrating down into the subcutis or even the skeletal muscle. They often have perineural invasion and wrapping around nerves. And this example, I mean, they don't have any atypia. These are usually very bland cytologically. Again, if you took this one duct right here or that one there, it almost looks like a normal eccrine duct, except that it's infiltrating down into skeletal muscle. So in this case, this was, I think, on the cheek, and it was way down below the subcutis and infiltrating all the way to the deep margin. So these are quite rare, though, but they're very, very treacherous because they are not cytologically atypical. The ducts are hard to see, and if I have concern for MAC, I often am going to ask for a complete excision or a deep enough biopsy that I can see the base of the lesion. I find that to be the most helpful thing to distinguish MAC from desmoplastic trichoepithelioma. Syringoma and basal cell are usually easier to sort out. This is syringocystadenoma papilliferum, or SCAP, is what we call it because it's easier to say. And it's an example of a cystic and papillary pattern. We have these cystic invaginated spaces that come down from the epidermis and branch down into the dermis. And then protruding into those spaces, we have papillary structures, okay? The papillary structures are lined by a double layer of columnar epithelium, kind of this basal layer here of basilar cells or myoepithelial cells, and then the lumen is lined by columnar or sometimes cuboidal cells, often with little apical snouting that kind of protrude off of the apical surface. And in the stroma, both within these papillae and around, you're going to see numerous plasma cells. So that's a classic pattern if it's easy to recognize once you know that this entity exists. These kind of invaginating cystic spaces with papillae sticking up into the lumen and the double layer cuboidal lining and the numerous plasma cells. And this often arises on the scalp and tends to have a high tendency to occur in conjunction with pre-existing nevus sebaceous. So I often will see these arising in a background nevus sebaceous that the person's had since they were a baby, and then now they're a teenager or an adult, and the lesion's growing and changing, and on biopsy we see a big scap in the middle. These are benign. There are extremely rare examples of malignant ones, but I think I've only seen like one of those. And this is a mixed tumor, chondroid syringoma, which I'm not going to go deeply into because it is basically like the skin equivalent of pleomorphic adenoma or mixed tumor of the salivary gland. So you all as head and neck pathologists are going to be very, very familiar with all of the features. But basically, it has a wide range of features, just like the salivary examples do. The ones in the skin can really run a wide range of different types of patterns and different arrangements. But they have cords, tubules, and ducts, and the background tends to be chondromyxoid or chondroid, sometimes with true cartilage or even bone. Other times, there's going to be no cartilage and just kind of a loose myxoid stroma, sometimes with adipocytes in it. And in addition to the ducts and tubules, of course, you're going to have areas that are sheet-like kind of arrangements or little islands of myoepithelial cells hanging out in the background as well. And here's an example that doesn't really have any cartilage, but tends to have myxoid change and adipocytes in the background. And this is one of those entities, when I see this on the face, if I'm anywhere near the parotid or another salivary gland, I'm going to recommend either physical exam or, if needed, imaging, just to make sure that this really is a lesion confined to the skin rather than an underlying salivary gland tumor that's pushed up into the skin. So sometimes I'm not given enough clinical information to make that distinction on my own, and in those cases I'm going to alert the treating physician to just, hey, make sure that this is really a skin lesion, not a salivary tumor. And here was one that actually had really beautiful bone formation and real nice, well-developed cartilage. But again, in the background, ducts and tubules and little islands of myoepithelial cells. Now, follicular tumors, there are many. They often have a lot of overlap, and each one looks a little bit different. So one of my dermpath mentors, Dr. Ron Rapini, likes to say that they look like snowflakes. Each one is unique and looks a bit different from the next. And no two are exactly identical. And I think that's a very apt description. So I'm just going to cover a couple select ones. There are many, Dr. Ackerman wrote a large textbook just about hair follicle tumors. So yeah, this is a very large subject, but we're going to talk about a few of the main ones. So trichofolliculoma is a good one to know about because it's going to have a central cystic space that will often connect to the epidermis, although you don't always see that connection depending on the plane of sectioning that your particular slide is examining. You got to get just a perfect cut on the microtome to see this thing open up into the surface of the skin. So a lot of times it's going to look like a cyst surrounded by lots of little tiny immature hair follicles that are emptying into the lining of that cyst. And here's an example. You can see blue basaloid germinative epithelium. These little bright red granules are called trichohyalin granules, and they're a feature you can see in the roots of normal hair follicles. This is evidence of inner root sheath growth. These little glycogenated cells here are the outer root sheath, and you can see this little tiny immature hair follicle is trying to form, and it's emptying directly into that central cystic space. So this is kind of like the mother follicle, and then these are the little baby follicles. And look at that dense stroma that almost looks like a papillary mesenchymal body. See, recognizing that stromal condensation around the basaloid cells is a really useful feature to recognize hair follicle differentiation. This is a trichoepithelioma. From low power, this kind of looks similar to that trichofolliculum. It's got a cystic space, but this one has a lot of islands of basaloid cells well away from that central cystic space. But again, you could say, well, that kind of has overlap. A lot of hair follicle tumors overlap with one another. And occasionally I've even signed things out as benign hair follicle neoplasm with the comment that this shows overlap between entity X, Y, and Z, but regardless, it's benign. Because that's the main thing that matters for patient care. Does this need any more treatment? Is this going to behave badly? And so the distinction here between a trichofolliculoma and a trichoep doesn't matter at all. It's just one of academic interest. And in trichoepitheliomas, this is the time where it's really nice to find the papillary mesenchymal bodies. And particularly if I'm in an older person who's sun damaged, I pretty much want to see good papillary mesenchymal bodies before I make a definitive diagnosis of a benign thing like a trichoepithelioma rather than a basal cell. Because sometimes basal cells can have some hair follicle differentiation. They can look kind of like hair follicle tumors. So finding the papillary mesenchymal bodies, to me, if I see good papillary mesenchymal bodies, that argues very strongly against basal cell. There are some people that believe that basal cell carcinomas can sometimes have papillary mesenchymal bodies. I personally don't think that I've ever seen a case that has convinced me of that. So I'm kind of not a believer, but you'll find other very smart people, probably smarter than me, who are believers in that. So you can decide what you want to do in your practice. But in my practice, if it looks good for trichoep and I see papillary mesenchymal bodies, I feel comfortable saying trichoepithelioma. If they're old and sun damaged and I don't see good papillary mesenchymal bodies and I'm not sure, then that's a time where I may say it's a basaloid neoplasm. I think it's a trichoep, but I can't see the whole lesion. Cytokeratin 20 can be helpful here because most benign hair follicle lesions, particularly trichoepitheliomas, will have scattered CK20 positive Merkel cells, benign Merkel cells that are just kind of hanging out and colonizing the hair follicle tumor, and basal cell carcinomas tend to not have those. So I find that to be helpful. There's been a lot of other stains people have proposed, and it seems like, to me, none of those are, I've never been convinced by any of those enough that I felt that it would overrule what I saw morphologically. But I do find CK20 helpful in select circumstances, and again, we talk more about that in that paper at the beginning. Now, I use the term trichoblastoma for things that are benign hair follicle tumors that are larger and deeper than trichoepitheliomas. Other people, they probably are closely related, if not variations of the same thing. Some people, have different views on this. But again, it's mostly arguing over what name to use for a benign thing, which doesn't really matter for the patient. But I think it's important to know that trichoblastomas can be quite large and deep, and they can occur particularly like in the scalp of older adults. So times where you might be kind of worried, but look, there's no way this thing's basal cell carcinoma. It's a circumscribed nodule that's not connected or even close really to the epidermis, and it's got its own stroma, even from low power, like 1x magnification. I think this was like a digital slide I did, 0.5x magnification. You can see the stroma, it ends right there. It's a very sharp cutoff from the surrounding background dermis. So I find that so helpful to find for not just trichoblastoma, but many hair follicle tumors, having their own stroma that's clearly distinct from the surrounding tissue is a very useful feature, and it's very characteristic of hair follicle tumors. Some trichoblastomas have little tiny nests like this embedded in the stroma. Other ones have very large nests and everything in between. Again, snowflakes, remember, each one's different. And this is the one I showed at the beginning, so I'm not going to belabor this, but they're blue nests with palisading, but again, no cleft, no mucin, and the stroma tightly wraps and hugs around the edge of the nests. And then finally, pilomatricomas are important to know about. They tend to be most common in kids, but I've seen many of them in adults, even elderly adults. So just because they're an older person does not mean that you should be worried about it. Pilomatricomas tend to have a mixture of these three things in varying proportion. Blue basaloid cells, which are recapitulating the hair germinative root cells. These sheets of ghost or shadow cells, which basically look like a sheet of keratinocyte with the nuclei totally dissolved and missing. So it's like a shadow of the original. Basically take this and delete all of the nuclei out and turn it pink, and that's the ghost or shadow cells. If I just see ghost shadow cells and this background granulomatous response, which is very common, I'll feel comfortable saying that something's consistent with a pilomatricoma just based on that. The blue basaloid cells are not always there. I've seen plenty of pilomatricomas that had no basaloid cells at all, that were just burnt out shadow cells with granulomatous reaction around them. But there are sometimes that these basaloid cells can be very abundant and they can be very mitotically active. And because of that, it's important to know about them, because those cases can have brisk mitotic activity, and they can really concern the pathologist if you've never seen one like that before. I've had many cases like that sent in for consultation. I used to take second opinion consults in my former practice, and I saw multiple cases like that where people were like, I think it's pilomatricoma, but there's 20 mitoses here. No problem in my book. Pilomatricoma is a nice benign entity to know about. Calcification and even bone formation can be seen sometimes. And again, this is a closer look at the ghost or shadow cells. There are very rare examples of malignant pilomatricoma, or if you like, you can call these pilomatrixoma. Whether you want to put a C or an X there is totally optional. But there are very, very rare malignant examples, but almost all of the ones that I've seen that were malignant looked obviously malignant at first glance, and it was only later that I started finding areas that looked kind of matrical. So I started at cancer and then said, oh, I think there's some matrical stuff. I think this is a matrical carcinoma. Only one time have I seen something that really looked microscopically like pilomatricoma, but clearly by clinical behavior and by how rapidly it was growing and infiltrating, that it clearly was malignant in my opinion. But otherwise, I feel like if it looks like a benign pilomatricoma, it almost always will be a benign one. So there's an example of the mitotic activity that can be very brisk in the blue. I mean, I've seen ones with 10 or 15 or even 20 mites in 10 high power fields. But the things that worry me, atypical mitotic figures or pleomorphism, or if you see infiltrative growth, although most of the time these come out as kind of a fragmented specimen, so I find that it's really hard to evaluate for infiltrative growth. All right, so that's pilomatricoma. Now let's go over a few things here before we finish up. I'm going to talk about a couple different spindle cell lesions, and then we'll talk about some melanocytic things. So one important spindle cell lesion that I want you all to know as head and neck pathologists is DFSP. And that's because DFSP is classically taught as a multinodular fungating mass on the trunk of young adults. And that surely is the classic example. But I worked with DFSP patient support groups on Facebook. I volunteered there for about 7 years, or maybe even longer now, about 7 years or so. And so I've met a lot of patients, and many of them we found had examples that did not fit this classic morphology. They can occasionally occur on the extremities, and I would say on a relatively common basis, they occur on the scalp, particularly the head and neck, especially the scalp. So it's a really important thing for people doing any pathology in the head and neck to know about DFSP and to know that the scalp is a relatively common site for DFSP. I've seen many, many examples on the scalp. And the other thing is that, yes, if you let them grow for years, they will become multinodular and fungating, but when they start out, they often have a very benign, non-specific appearance clinically, and I cannot tell you how many hundreds of people I've met and cases I've seen in real life where they were clinically thought to be a cyst or a scar or a lipoma or a keloid or a dermatofibroma, and those things often result in delay in diagnosis and delay in biopsying the lesions. So it's a very, very common finding where they'll think it's a cyst and the surgeon will go to shell it out, and their post-op diagnosis is not a cyst because it clearly wasn't cystic once they cut into the lesion. Okay. And so we'll show these in a minute, but they're bland spindle cells, often with a storiform pattern. So despite the fact that it's a sarcoma, you almost never see pleomorphism of any significant amount in DFSP. And that's because it's a translocation sarcoma. Most translocation-associated spindle cell tumors have uniform monotonous nuclei and lack pleomorphism. There are, of course, always exceptions to the rule, but I think that that's a really important take-home pearl that I learned from one of my mentors, Dr. Mark Edgar. And so the translocation most commonly seen is collagen 1A1 PDGF beta, and you can test for that by FISH or RT-PCR if needed. But new uncommon variant involving PDGFD and a couple of different partner genes has been described. So I like to, if I'm worried about DFSP and it's not a straightforward case, I usually will go to FISH. And if this FISH is negative, then I like to go on to PDGFD as a follow-up reflex FISH. In straightforward cases, molecular, in my opinion, is not needed, but I do it on cases where I'm either pretty sure it's DFSP, but I'm not certain, and they're going to go do a big surgery, or much more often where I'm pretty sure something's not DFSP, but it's a bland CD34 spindle cell thing, and I'm not able to classify it otherwise, and those are the cases where I do the FISH just to be sure I'm not missing something like a DFSP. All right, so the storiform pattern, this beautiful swirly, whirly growth, it's very, very visually appealing to look at. You can describe it with 100 words, but really you got to just see it. A lot of DFSP have that, but I've seen DFSPs that didn't have storiform, and I've seen other things like dermatofibromas and a variety of others that do have storiform patterns. So that alone is not enough. All right, what we really want to see with DFSP is those bland, swirly, whirly spindle cells infiltrating and entrapping adipose tissue with this so-called honeycomb pattern. You'll see islands of fat trapped in the midst of the tumor. This all used to be subcutaneous, and the tumor has completely replaced most of it and just left these little stranded islands of fat wrapped around by tumor very tightly. right? And this is the kind of almost Swiss cheese or honeycomb pattern, very characteristic. So it can run a range, but I think it's important to know that sometimes the subcutis gets overrun by tumor, and all you'll see is a tiny little bit, and the rest of the tumor will look like solid story-form bland spindle cells. So I remember when I first saw that in fellowship, I was very confused because I thought, this doesn't look infiltrative, it looks smooth bordered. And Dr. Weiss told me it's because the tumor's grown all the way to the edge and it's replaced all the fat, and only a tiny little bit of fat trapping is seen. So that's a really important thing to know about, and I particularly feel like I see that scenario where there's very little fat trapping because the tumor has grown over all the subcutis. I see that most often, I think, in the scalp, where the tumor kind of grows down to the galea or the periosteum and then kind of hits a wall there and spreads out, and in the middle all the fat gets replaced except for just a tiny bit. So really important to know about that. CD34 is a very sensitive stain that's going to be positive in the vast majority of conventional DFSPs. But is not, of course, specific at all. It stains lots of different fibroblastic and myofibroblastic types of, fibroblastic entities, and also can stain things, like spindle cell lipoma, which can sometimes have overlap morphologically with DFSP. So very helpful as a screening tool, but make sure that you don't let CD34 lead you astray. It stains many different things. Sensitive, but not specific. Now here's an example where you can see the conventional DFSP over here, but then an abrupt transition to a very cellular nodule. And going closer, that cellular nodule still doesn't have pleomorphism, but it's much larger cells. They're much more tightly packed together. There's more mitotic activity, and they're arranged in these kind of sharply intersecting, acute angle intersecting herringbone pattern fascicles. So this is an example of fibrosarcomatous transformation in a DFSP. And these, in some studies, have shown that these do have a somewhat higher rate of aggressive behavior like metastases. But the treatment is basically, as far as I understand it, most people agree that the treatment is pretty much the same. You excise these tumors either with wide local excision or Mohs surgery to achieve widely negative margins. So that's the goal of treatment, and in select cases, other modalities can be applied as well, but usually complete excision with negative margins is the mainstay of treatment. And I think I've seen well over 100 DFSPs now, and in my own personal practice, I believe I've only seen 1 or 2 metastatic DFSPs. So, but it does happen sometimes, but local recurrence is a much bigger issue usually. All right, now I'm going to just briefly touch on this. Dermatofibromas, or also known as benign fibrous histiocytoma, they most often occur on the extremities or sometimes the trunk. But I think it's important to note that they can sometimes occur on the head and neck. And when they do, they tend to look different than the classic conventional dermatofibromas. They tend to be a bit bigger and they are more cellular, and they're often kind of a nodule in the deep dermis or subcutis. So I've often seen these where clinically they look like a cyst and something nondescript because they're deeper down, they don't have much change of the epidermis over it. So they'll look like a cyst or some other lesion, and then once they're excised, we see that it's a cellular dermatofibroma. And I tend to see these most often in kids and young adults. So it's an important thing to know that dermatofibromas, although uncommon, definitely can occur on the head and neck, and they sometimes look a bit different than the ones elsewhere in the body. The things that can help you in sorting out dermatofibroma from DFSP is, number one, there tends to be a bit more cellular variation in the size and shape. The cells are more plump, and they often have a bit of atypia and even can have scattered obvious pleomorphism, or so-called monster cells. Mitoses scattered in the midst of a DF is a very common finding. And the other thing is you'll often find a little bit of hemosiderin, you'll find some multinucleated histiocytes, you can find some foamy cells, sometimes you find little blood-filled spaces or hemorrhage. All of those features are very helpful in pointing towards dermatofibroma and away from DFSP. And I have some various videos on dermatofibroma and DFSP on my YouTube channel, or on that directory on Kiko that I showed the link for at the beginning of the talk. So you can go check those out if you want to brush up on that a little bit more. And sometimes DFs can extend down into the subcutis, and sometimes they can even be totally centered in the subcutis. So when they do that, they tend to send little fingers out into the fat, and that can get people really concerned to think it might be DFSP. One thing is that you often will find some fat necrosis around these little areas, whereas in dermatofibrosarcoma protuberans, you tend to not really see that. The fat seems to be kind of entrapped, but otherwise more or less normal. Whereas here, the fat begins to break down and get a little bit of fat necrosis and kind of some inflammatory response. That's kind of a subtlety, but I do find that helpful, and that was described in a paper about a year or so ago by the group at University of Michigan, I believe. Very helpful feature. And cellular DFs can have that kind of herringbone fascicle pattern that can make you think of DFSP. So it's important to know, and again, if there's any doubt, to me, if I see this, if I can find other areas that look more classic for DF, that's helpful. But if I have a doubt, I can do immunostain for CD34, or I can do molecular if needed, okay? And sometimes cellular DFs can even have a little bit of necrosis, and that can be a little scary. Now, CD34 in dermatofibromas, particularly the bigger cellular ones, really important to know that there's often a rich vascular network, and those are going to stain with CD34, but the tumor cells are going to be negative, except at the very periphery. The normal dermis has a lot of CD34 expression because of dendritic cells that live there, and those get kind of pushed out of the way as a dermatofibroma grows. But what happens is they pile up and they kind of make this thick rim of CD34 expression at the periphery of the dermatofibroma. So I like to call this the CD34 positive halo, because if you can see the whole lesion from low power, it'll look like a halo or ring of more bright staining at the edge of the DF, and then the middle of the DF is going to be totally negative except for the background vessels. So just be aware of that. If you see some bright staining, go look at the middle of the dermatofibroma and it should be dead negative. It would be very unusual to see areas like this in a DFSP. With the one exception, I forgot to mention that the fibrosarcomatous DFSPs sometimes do have loss of CD34 expression, so that can be a challenge in those cases. Nodular fasciitis is classically on the extremity, but sometimes it occurs in the head and neck. And it can be in younger patients when that happens, like in kids, and it can be a bit more cellular and funny looking and can be down in the muscle. So it's important to know, though, that nodular fasciitis is well described on the head and neck. A couple of tips and pearls here about nodular fasciitis. They tend to be small. If you see a lesion that you think is nodular fasciitis, but it's bigger than 3 centimeters, you got to think twice about that. It's not that it couldn't be 4 centimeters, but it probably can't be, 10 centimeters or anything like that. Obviously, on the head and neck, usually things are going to get sampled before they get that large, but it's just important to know usually they're small. And even from low power, you can see cystic spaces. Nodular fasciitis often has cystic myxoid degeneration. I find that very helpful, incredibly helpful clue that is usually present in most nodular fasciitis. So look for those little myxoid cysts where the lesion is breaking down. And they also have this so-called tissue culture arrangement of myofibroblasts. I didn't grow cells in culture anytime during my medical training or undergrad. Maybe you did, but tissue culture doesn't really visually work for me. I think loose and feathery is the terminology I like to use, but whatever visual term works for your brain, that's the term you should use. It doesn't matter what term we say something looks like. It matters that we get the diagnosis right for patient care. So again, look at the myxoid cystic breakdown. It's subtle, but you can see little myxoid bluish pockets that are breaking down and degenerating here. And then these loose feathery areas are so-called tissue culture areas, and other areas will have little short fascicles of myofibroblasts. Some cases like this one are much more pink and have more dense sclerotic collagen. When the lesions are earlier and just starting out, they're much more cellular, then they get cystic breakdown, and then some of them over time get sclerosis and kind of scar down a little bit almost, if you like to think of it that way. You can still see some of that loose feathery tissue culture area here. Mitoses are often present and can sometimes be abundant, particularly in the more cellular early lesions of nodular fasciitis, but you don't want to see hyperchromatic pleomorphic nuclei. That should really make you think twice about nodular fasciitis. Now here's an example of reactive myofibroblasts in the setting of, this was from a melanoma biopsy site. They can look kind of weird, right? The purplish amphiphilic cytoplasm is a helpful clue for myofibroblasts. I have a couple videos on my channel about how to tell myofibroblasts apart from other things. I really recommend for my trainees and for everyone really who's trying to learn more soft tissue pathology, study post-surgical reactive changes every chance you can get to get an idea of how weird and wild sometimes reactive myofibroblasts can look. Okay, I think that anytime you know that something is not going to be tumor, you know it's going to be reactive, study those cells, and then in a hard case where you're not sure if it's a reactive process or a tumor, then you can get a better idea of the range of features. That goes for looking at squamous epithelium, for looking at reactive myofibroblasts, for looking at melanocytes in sun-damaged skin, getting to feel the range of normal for reactive processes. I mean, that can be really hard. Dr. Weiss at the beginning of my soft tissue fellowship said, one of the main goals of fellowship is for you to be able to sort out neoplastic soft tissue lesions from reactive and fasciitis-like lesions, because that can be really, really hard. And so this is one way to increase your skills, is to study reactive biopsy site and post-surgical changes. Now, what about these wild-looking cells? So these big cells are kind of the one exception to the rule. They're kind of atypical, if you like that terminology, and you can see them in the setting of a background that looks like nodular fasciitis. We've got this loose kind of myxoidy background with extravasated red cells, which some people find very helpful for fasciitis. And we've got these spindle and stellate myofibroblasts, but then we've got these big, huge ganglion-looking cells here. So these cells can look pretty scary if you're not familiar with them, but once you know what they are and you see them in the background of what looks like otherwise fasciitis, these ganglion-like cells, when they're abundant, you can call this proliferative myositis if it's in the muscle, or proliferative fasciitis. I mean, to me, that's just two names for the same spectrum of thing. And so basically you have these large ganglion-like cells, but they're in a loose, feathery, myxoidy background that looks just like nodular fasciitis. But these can be pretty scary when you see these plus mitoses. And occasionally, especially in kids, you can get a very cellular variant of proliferative myositis where these cells are packed tightly together, and those can be quite challenging. And I have certainly struggled with these cases in my own practice. Even after doing training in soft tissue pathology and seeing many examples, I still find ones from time to time that give me pause and anxiety before signing them out. What's really helpful is if you see these skeletal muscle fibers suspended in the loose fasciitis background and then the scattered ganglion-like cells. So this pattern of patchy intermingling of splayed apart, sometimes atrophic skeletal muscle with intervening stuff that looks like fasciitis with all these scattered ganglion-like cells, that to me is very reassuring pattern from low power. This pattern is very reassuring for proliferative myositis. So again, start at the low power. Don't go straight to high power. You're going to freak yourself out when you look at these. And here's another example just to show you. This one was a little more pale because of the scan, but just to know that the myxoid change is sometimes not always as blue as that first example. But again, loose feathery myofibroblasts, extravasated erythrocytes, which are often present, spindled and stellate or triangle-shaped cells. All right, finally, melanocytic neoplasms. I'm going to try to get this done without going over. So let's talk about the basic features that you should see. We could talk about nevi and melanoma for days and days, but these are some features that are warning signs for melanoma. None of them are by themselves totally 100% definitive of melanoma, but I'm going to show you some classic examples so that you can know. So side-to-side asymmetry, if I see a melanocytic lesion, if I draw a line down it from the surface of the skin down to the subcutis, if the right side and the left side look different, I stop and think, am I sure that this is benign and not melanoma? It doesn't mean that it's melanoma, but it's a warning sign. If I see one side, the right-hand side of the lesion looks different than the left, then I got to figure out an explanation for why that is. Because nevi often are symmetric, but melanomas have a tendency to kind of grow differently on one side than on the other. If I see pagetoid spread, confluent growth, or an abundance of single cells in the epidermis, if I see lack of maturation in the dermis, severe cytologic atypia, or dermal mitotic activity. Those are all features that make me think about melanoma. And again, I can see nevi that have mitoses in them, or have atypia, or have a weird pattern of maturation. You can see confluent growth in a nevus that's been, recurrent over a biopsy site. So again, there's exceptions to every one of these things. And that's part of why DermPath is very challenging, because none of these rules are perfect. All right, so there's the caveats for all of that. So you got to put all of it together. This is classic pagetoid spread. Very atypical melanocytes, even with some mitotic figures, and they're spreading with a pagetoid pattern like buckshot into the epidermis all the way up to the top of the epidermis. So that's very characteristic. The other thing is if I see atypical melanocytes in the epidermis and a bunch of solar elastosis in the dermis, I'm going to be considering that potentially melanoma until I can find another explanation. It's not that you can't see an atypical nevus in old sun-damaged skin, but you got to be very, very careful, especially on the skin of the head and neck. That's a time where if I see atypia in sun damage on the face or the scalp of an older person, I am extremely cautious in that setting because many of those lesions are going to be melanoma, probably most. This is an example of confluence, where the basal layer of the epidermis is being replaced by melanocytes. And especially when you've got numerous atypical ones like you see here, well, this is pretty easy. In practice, though, confluent growth, I think, is something that's easy to talk about, but in practice, it's actually a lot more challenging, and it's not usually as straightforward as this. So I'm going to teach you that feature, but I'm going to tell you that it's really something that actually is, I think, challenging to evaluate in practice, unless it's really dramatic like this case here. Sometimes confluence causes this artifactual separation of the epidermis and dermis, the so-called unzipping artifact or the melanocytic blister. This is not a blister in real life. In vivo, it's an in vitro artifact where there's so many melanocytes that the epidermis gets pulled apart from the dermis during tissue processing from all the shrinkage of the tissue that happens. There's just not enough basal keratinocytes with hemidesmosomes to hold it down to the dermis. So if I see that, that is a good clue for the presence of confluent growth. And here there's also pagetoid spread, and there was probably atypia in the dermis, if I recall from this case. Maturation is another thing where we talk about it a lot, but in real life it can be tricky to evaluate. It's usually only very helpful in really big, thick lesions, where you have a lot of melanocytes going way down into the dermis. So here you can see huge nests and large melanocytes all the way down to the deep aspect of this lesion. That's very abnormal. Normally, nevi start with larger melanocytes and larger nests up top, and as you go deeper, they trickle down and become little single cells that trickle out into the dermal collagen. And I've got whole videos about nevus and melanoma on my Kiko page and my YouTube channel, so you can check that out if you need some refresher there. Obviously, if we see big, ugly, atypical cells, I'm going to be very concerned for melanoma, or if I see dermal mitoses, particularly massive, atypical ones like this. So these are obviously all very dramatic examples. In real life, it can be a lot more nuanced and subtle. And I still struggle with hard melanocytic lesions basically every day of my practice, even after being in practice for about 9 years now. So as a board-certified dermatopathologist. So if you find them challenging, you're in company with all of us. Most dermpaths would agree that melanocytic lesions can be very challenging. So I think the most important type of melanoma for head and neck pathologists to know about is lentigo maligna. And that's because the most common place for it is on the head and neck of elderly sun-damaged people, usually Caucasians. And what you're going to see is single cells or sometimes nests of atypical melanocytes kind of scattered and trickling along in the sun-damaged skin with an atrophic epidermis. This is a very florid example. Some examples are much more subtle and show only single cells with no nests, and those can be extremely challenging to diagnose. They tend to kind of have areas where they will grow more densely, and then they'll skip, and then you'll find another area further away that has some more. And so skipping patchy growth along a broad zone of epidermis of single melanocytes in a sun-damaged face of an older patient, that really worries me for melanoma, okay? And also you often have lymphocytes kind of attacking the tumor. This is a host response, and that can be a really helpful clue as well. And here you can see nice confluent growth, and these melanocytes are vacuolated, but sometimes it's more subtle than this. Now, one thing that happens in some melanomas, particularly I feel like I see it in lentigo maligna, is you get regression underneath the melanoma. And whether this means the tumor actually invaded or whether this is a relationship to the host response is not fully clear. But the point of why I'm bringing it up is if you see a zone of pink that's pushing down solar elastosis, that means that this pink collagen is new. It got there after the person became old and sun damaged. It was not their normal collagen that they were born with. So you have to think, why is that collagen there? Is it there because they had trauma or a previous biopsy and now we have scar? Is it there because there's a desmoplastic melanoma depositing collagen or some other tumor? Or is it there because there's regression? And in this case, you can see a little bit of unzipping right here. So it's evidence of confluent growth, large nests of atypical melanocytes here, and regression-like changes in new collagen pushing down the elastosis. That's melanoma until proven otherwise. That's a really good clue. It only works in old sun-damaged skin. If you don't have a bunch of elastosis, this trick doesn't work, but it's a really helpful trick in older sun-damaged patients. And so regression is usually a mixture of disorganized pink collagen and lymphocytes scattered in here, and then melanin-filled histiocytes, or what we call melanophages, in varying proportion scattered in the dermis. And up here you can see the confluent growth of atypical melanocytes representing the in situ lentigo maligna melanoma in situ up above. So I would report this if I didn't find anything in the dermis. I would call this melanoma in situ lentigo maligna type with abundant dermal regression. So basically, when I see a lot of regression, that means there could be invasion that has gone away or that we've not sampled, and they should think about that and keep it in mind. Some people have advocated for measuring the depth of regression. I personally do not like that idea or do it, but I have met other people who do, but I don't do it in my practice. So you can take that or leave that. All right, now the other thing I want to point out is that lentigo maligna type of melanoma can sometimes mimic the pattern of dysplastic nevus. So I'll show you a dysplastic nevus in a minute, but this is a melanoma, but it has elongated rete with bridging of nests across the tips of the rete. And so I have seen multiple examples of these kind of melanoma that had been seen on the face of an old sun-damaged person and called dysplastic nevus with moderate atypia or severe atypia. And then, of course, a year or two later, when it continued to grow or recurred, or when the full excision was done, it was full-blown obvious melanoma. So I want to alert you of that, particularly in older sun-damaged skin. The lentigo maligna type of melanoma has this tendency sometimes to grow with a pattern that looks predominantly nested and has bridging across rete and otherwise resembles dysplastic nevus. Be very, very, very cautious. I almost never, let me just put it this way, I am extremely hesitant to make a diagnosis of dysplastic nevus on the sun-damaged face or scalp of an older person, okay? I have done it before, but only with multiple stains and deeper sections and a comment that despite the age and the sun damage, I think that the stains and everything point to dysplastic nevus, but if this is part of a bigger lesion, it may not be right, etc., etc. So I do it with a lot of hedging and trepidation. I do see sometimes dysplastic nevi on the sun-damaged skin of the shoulder or the arms of older people, and even then I'm still cautious. But on the face, it's extremely unusual. Even in younger people who have a lot of dysplastic nevi, I don't tend to see very many dysplastic nevi on the skin of the face. So if they're old and sun damaged and it's the face, I would strongly recommend that you not call something dysplastic nevus. And if you have any doubt, send that for a consult to someone. Because if you call it dysplastic nevus, you'll usually be wrong. And I've seen many examples of that. So here's that same lesion, and look elsewhere in the lesion, you can see confluent growth of atypical melanocytes all the way down this eccrine duct, which is a very characteristic feature of melanoma. It's basically a type of confluent growth. So here's an example of a real dysplastic nevus, just to give you the idea if you haven't seen one before. They have melanocytes down the tips of elongated rete with this bridging. So that's a true dysplastic nevus, which again, I don't see often on the skin of the face. But just to give you an idea, they really can, melanoma in situ really can look similar to that pattern. So it's the sun-damaged face skin is the clue that probably you're not dealing with a true dysplastic nevus. You're dealing with a melanoma in disguise. Solar lentigos are very common on the face, and clinically they look very much like, and sometimes almost identical to, lentigo maligna. That's where the name lentigo maligna comes from, basically, is it looks like a lentigo, but if you leave it alone and it grows for a long time, it can behave in a malignant fashion. So this is a common thing that I see every day in my practice, a biopsy of a pigmented lesion on the sun-damaged skin, where the dermatologist says lentigo versus lentigo maligna. Okay, despite the name, they are unrelated at a microscopic level, although they can sometimes mimic each other. So solar lentigos are basically keratinocyte lesions where you have increased melanin pigment in the basal layer keratinocytes, and you can either have a thin atrophic form or you can have this form where you have elongated rete with these kind of hockey stick shaped or L-shaped rete, or some people call these dirty puppy dog feet, like a little dog walked through some mud, if you like. I think that's a term Dr. Rapini likes to use. Sometimes these little dirty puppy dog feet, these rete tips can get tangentially sectioned, and they look like little islands in the dermis, which people can confuse with nests of melanocytes. If you have any doubt, you can do an immunostain here, like a SOX10, to prove that these are not all melanocytes, that they're actually keratinocytes. But this is a solar lentigo, and I do occasionally see actinic keratosis. I often see actinic keratosis and lentigo coexist together. Also, I sometimes will see solar lentigo with melanoma in situ in the background. So just because there's a lentigo there, don't stop looking. And if you've got any doubt, you can do a stain like a SOX10 to help you sort it out. All right. This is a table from my book that you can look at later if you like. This is, in my opinion, the best options of immunostains for melanocytic lesions depending on what the scenario is. So when I'm looking at for melanoma in situ, for pagetoid spread or confluence to help me distinguish melanoma in situ from, say, a nevus or a solar lentigo, I personally like SOX10, or if you don't have that, you can use MITF. Some people use MART1, although I think you got to be more cautious because it can lead to overinterpretation if you're not used to it. And again, you can read over this table later. I'll include this in my handout so you'll have that for reference later in your practice if you like. This is based on my personal experience and my views. Now, this is an example of a classic melanoma. What SOX10 will look like. You're seeing confluence, complete replacement basically, going down reedy and up in between reedy, back and forth again and again. That's confluent growth, classic slam dunk. Again, in real life, it's not always going to look that good. I'll tell you, it's rarely going to look that good. You can also see prominent pagetoid spread here. So that's an example, a textbook classic example of what you want to see in a melanoma. Again, in real life, it's more subtle. Now, this is what you would see if you do SOX10 on a solar lentigo. You can see that all this pigment here, these are not melanocytes. Melanocytes are often not very heavily pigmented. The pigment, if you see a ton of pigment in the epidermis, it's usually going to be a keratinocyte. In the dermis, it's usually going to be a melanophage. There are exceptions to that rule, but I would say as a general rule, densely pigmented cells tend more often to not be melanocytes, which is kind of paradoxical, but that's the truth. So you can tell that by doing a SOX10, and look, all these pigmented cells, turns out they're negative. It's actually these little pink or gray cells right here. Those are the ones that actually are the melanocytes. And sometimes solar lenticos can look like this. They can be atrophic and flat with no elongation of reedy. So I think there's two different patterns. I call both of them just solar lentigo in my practice. Sometimes they're thin, sometimes they have long reedy. I honestly feel like I see these thin atrophic ones even more than the ones with the long reedy. All right, so look, here's an older man with chronic sun exposure, a lesion on the face. They clinically were worried about lentigo versus lentigo maligna. What stain is this? Well, I'll give you a second to think about it. This is S100. I would recommend you not use S100 when you're looking for confluence or pagetoid spread, because look at how busy it looks. It looks so scary. It looks like melanoma. The reason is S100 doesn't only stain melanocytes, but it also stains Langerhans cells and some other dendritic cells. Langerhans cells, of course, live in the mid-spinous layer of the epidermis. So normally you're going to have abundant Langerhans cells both in the epidermis and the underlying dermis. If you do an S100, it's going to be a lot more positive than you expected, and it's going to lead you astray. It's very difficult to interpret. So I think S100 is a very dirty immunostain, which is fine. I mean, for certain things, I do like S100, but not when I'm looking for melanoma in situ. I recommend against using it because it's too difficult to interpret. Now, I think another thing here is if you're using S100 in the skin for something else, you should expect to see a lot of background staining. If you don't, if your S100 looks totally clean and lacks background, you got to double check your control and make sure your S100 worked. So I expect to see a dirty background of scattered cells in the dermis and epidermis on an S100 stain if I'm using S100, say, for a nerve sheath tumor or something else. If I don't see that, then I go check the control or have it repeated because I expect to see it. So in contrast, here's the same exact case, a little bit different cut, so it looks a little different, but this is that same case I just showed you. Here's the S100, and here's that same area on SOX10. Look at how strikingly different. Here you can just see scattered melanocytes along the basal layer. In sun-damaged skin, they're going to be increased in number. That's totally normal to see, and sometimes that can be a vexing problem when you're looking at margins, but this is why I like SOX10 way better than S100. Now, here's MART1, or Melan-A, if you like that name better. And if you have access to doing a red chromogen on your SOX10 or your MART1, I highly recommend that when you're looking at the epidermis and there's a bunch of background pigment. It can really be a lot more useful to use a red chromogen rather than a brown. Not everyone has access in their lab, but if you do, I'd recommend trying to get your MART1 and your SOX10 so that you have a red version, a red chromogen version of those. It has really removed a lot of headache from my practice. The reason I caution against using MART1, and again, a lot of dermpaths, especially I feel that dermpaths who trained maybe more than 10 years ago, I feel like they're more often using MART1 because MART1 was around before SOX10 had been discovered and made commercially available. So I used MITF in my fellowship, and then early in my practice had access to SOX10, so I got more comfortable with using that. So if you already know how to use MART1 and are comfortable with your threshold for how to evaluate it, then great, keep doing it. But if you're just starting out, I would recommend trying to use SOX10. I think it it tends to be an easier way to evaluate. The reason is that MART1 stains the cytoplasm, and melanocytes have these dendritic branching processes that stick out to their sides. And so you're going to see a lot more MART1 staining. It makes it look like there's more melanocytes here than are actually present. And that's because not only are these melanocytes here sticking out their dendritic processes to the side, but also you're seeing dendrites that are coming from melanocytes that are deeper into the block and some that are outside the plane of section towards us. I hope that makes sense three-dimensionally from home. Usually I use hand gestures to show, but I can't really do that now. So in any case, the point is you're going to see a lot more cytoplasm, whereas if you use a nuclear stain like SOX10 or MITF, it's going to just highlight those nuclei, and it's not going to lead to this very busy appearance. So here's a contrast. There's same tissue, same patient, same sample. This is what the MART1 looks like, and there's the SOX10. So I'll let you decide for yourself. I just find that it's that MART1 tends to make me a lot more worried, and a SOX10 will make me think, oh, that's not as bad as I thought it was. So you can check that out for yourself. And I think that brings us to the end of our presentation. I hope that those pearls are helpful to you in your practice. And I know that was fast and furious, but it was a lot of ground to cover in an hour and 15 minutes, and hopefully that will help you. Thanks so much for the invitation, and have a great day.